Thanks for having me. This is my fourth time speaking at COS, and I'm glad to be here. This is a form of a talk that Ron asked me to give at his annual meeting last year. And then really what I did was I took my, I gave the OPSPOM lecture this year at ASCRS, and so I've altered this talk for y'all because I really want this to be a reflection on how God has used me to be a specific instrument of His grace against significant resistance that there's been. There's been several times, you know, over my career where I've been chosen to join a few colleagues to move things forward here, and a few where I've played a seminal role in developing something new, or I've changed the way that we all do things. Things like, you know, not all the struggles don't always turn into successes that change the world, but God wants us to go through those trials and struggles to move things forward, and so we'll talk about some of those things. These are some of my, you have to have a strategic partnership with industry that has made a huge difference. These are defense contractors in the fight to push back the darkness. That's how I look at them. And so, look, patients expect us to be doing everything possible to help them to save their vision. Like, in fact, they demand it of us. And we need to put them first. We need to act before they go blind. We have to ask patients what they want. We shouldn't assume. Saying I'm fond of is that I'm content but never satisfied. We can always do better. We don't have to be a victim of our training. I mean, 80% or more of what I do now, I didn't do during my residency or fellowship. I mean, even the phaco tools are radically different. Think of how far we've come. If I wanted burst mode when I was a resident with that legacy, the Alcon legacy I had to tap my foot, you know. Now we have, I own 2 Unity machines with 4D phaco and a computer chipped handpiece that prevents surges, and a phaco tip coated in a polymer to prevent capsular rupture. Finally, no matter how good we get at a procedure or technique, we need to always be prepared to improve upon it and have the courage to abandon it. There are, in fact, three of the things that I sort of became known for, I totally walked away from. So, the Reverend Martin Lloyd-Jones' preaching style was described as logic on fire, and I ascribe to be logic on fire when I speak about interventional glaucoma. But you know, doing so has come at a cost. Breaking up the cabal of mediocrity can be a dangerous calling, because when you challenge consensus, you're not immediately seen as forward thinking. You're often first seen as wrong, and sometimes even a problem. But over time, if you're right, that changes. You go from being questioned to being followed, from being dismissed to being cited, from pariah to pioneer. And that journey, that tension is what we're going to talk about today. So my interventional glaucoma journey started with my fellowship. This is Peter Netland, with whom I trained when he was the director of glaucoma in Memphis, at UT Memphis. He taught me by example to be bold in fighting against convention and to use logic, experience, and evidence to take best care of patients. But also, if the evidence didn't exist, then you must make the evidence. This is Peter with our dogs. He is the animal whisperer, and on the right is my wife Ann and I with Peter at AGS this past year. So look, consensus lags behind truth, and it's this gap where our patients lose. The gap between consensus is where Satan's dancing, you know, and our patients don't live on the timeline of consensus. They live on the timeline of progression. The reign of trabeculectomy has ended. People still need filtering surgery sometimes, but it doesn't have to be just a hole in the eye covered by sclera. We feel so good about ourselves, declaring how nice your bleb is, Mrs. Smith, while the patient looks at us like we're nuts because they can't see. So back to Peter Allen, the journey to do safer surgery. The Express, some of you remember the Express shunt, it's still for sale. It was a steel implant that was originally designed to go through a small posterior conjunctival incision, tunneling up into the anterior sclera into the AC, and just like one stitch, so no flap. It was sort of marketed as an easy filtration surgery, and every glaucoma specialist in the early 2000s saw a bunch of these that were referred for flat chambers or more likely an exposed Express with hypotony, infection, or both, which really poisoned the glaucoma community against this device. However, the idea of a more controlled trabeculectomy was a good one, only it needed a scleral flap to fix it. So in 2003, while I was his fellow, Peter Netland was approached by the company, Optinol, that made it the Express to verify that under the scleral flap technique and verify that it was viable and worthy of our efforts to do a larger trial, which we did because the evidence didn't exist, so we made the evidence. This was our first proof of concept large retrospective trial showing significantly less hypotony and choroidal effusions with the Express compared to TRAB. It wasn't even close. And then eventually there was a large randomized controlled multi-center trial where we observed far more rapid visual recovery of vision with the Express compared to trabeculectomy, and vision recovered to baseline at 1 month in the Express group compared to 3 months in the TRAB group. And the total complication rate was significantly higher in the trabeculectomy group. So, we're trying to do better. We're trying to be safer. But it was a fight because people don't like the change. They don't like to do things differently, and they don't want to be in a position of anxiety and worry because this is how they've done it before. It's our natural state to go to the path of least resistance. I've dedicated my career to being uncomfortable. So these are the types of things that were said to me personally or heard from the podium about the Express. So you're putting a nail in the eye. It's too expensive. I heard a lot of that from Canadians. It's too expensive. The sutures alone control the resistance to flow. The Express adds nothing. The surgeons that use the Express are just trying to make more money. I heard that in Abu Dhabi, of all places, at World Glaucoma Congress. And this is the last one that was said by a prominent leader in the AAO. That company should be put out of business. True story. Well, the opposition to new techniques, it's not a new thing. In the early days of IOLs, the establishment at the AAO and other major meetings only let the complications be talked about. Like only things about IOLs and phaco that were ever talked about were the complications. It was thought more ethical to leave someone aphakic than to implant an IOL. Truth. But things kept improving, and history is written by the victorious. How many ophthalmologists under 40 even know about this? The implantation of an IOL is an experiment which should not be performed on human beings. Sir Stuart Duke Elder. Once IOLs became standard, however, FDA approved in 1981, the narrative shifted to Ridley versus the naysayers. But I really don't want you to forget how far we've come. So eventually we created the evidence that followed for wider acceptance of the Express. Then in 2009, we went from pariahs to pioneers when Alcon bought Optinol. All of a sudden, most of the Express naysayers were on the Express train. The new head of surgical glaucoma at Alcon, which was a position that didn't even exist before. Because remember, these are companies that were, Alcon was, and it was phaco and IOLs and drugs. And so they had to create a new position. He came up to me and he said, do you know that you've implanted more of these than like anyone alive in any country? And I was just like, no, I didn't know that. And I say that because I don't do them I don't even do trabeculectomies anymore. So, but when we knew that that we had to do better. And this is just a little bit about the interventional glaucoma evolution. It's really, interventional glaucoma is really about catering a surgical plan to each individual patient. And the adversity we've experienced from the Express hairs only really emboldened me to keep thinking differently. Express was a safer TRAB, but it was still a TRAB. And we had a long way to go. But it was really just a start because we needed something better for people with mild to moderate glaucoma. So, how many know about Ologen? Have you heard of Ologen? Okay, so a few of you. All Ologen was this wound modulator made of collagen. And the thinking was you'd put it under or over the scleral flap and it would help modulate the wound healing. And it worked beautifully. Because if you look at the blebs, I'll show you some blebs here in a minute, but I mean, that's a bleb with Ologen, and it's just this nice physiologic bleb. And it was introduced around 2009, 2010, and somehow I get myself in these situations. By God's grace, he makes it so that I'm the one who's approached by the company saying, hey, can we think we have something here. They approached Bob Rich in New York first, but he had never done the surgery, and they really wanted me to start to make it take off. And so, like with the Express, we published a proof of concept retrospective. I mean, the blebs with Ologen versus mitomycin, the one on the left you're not worried is going to get endophthalmitis. The one on the right, you are. And so we proved that. I mean, that's self-evident if you understand wound healing. And then there was, we eventually had some data. We showed there was no significant difference between either group for the rates of achieving an appropriate post-op IOP with or without medications. But both groups had similar rates of complications. One patient in the mitomycin group lost light perception after suprachoroidal hemorrhage. But, and then I started using it for other things like to cover tubes. Dave Stevens, who I think presented his data at this meeting about use of Ologen to cover a tube. But then there's a fight for that too, and they're like, well, it showed that they work the same. Well, yeah, it showed the same, but what was weird was in that major clinical trial that we did comparing the mitomycin versus the Ologen, I couldn't get any of the investigators to release their photos, which showed the amazing, it was obvious the difference, and they wouldn't publish the photos. It was almost like it was a bizarre veil of darkness preventing what was obvious benefit to patients being presented in an appropriate way. It was so frustrating. I was like, it was just like, it's right there, people, And then the other thing is that people don't like change, and so they were doing this technique just like they would do a TRAB, and so they would they would tie the sutures really tightly, and just like a mitomycin TRAB, but they didn't realize that the Ologen would tampen out the flow some, and if you have stasis, you have failure. That's a secret of all glaucoma, is stasis equals failure. With any glaucoma surgery, if there's no aqueous moving through it, the thing will fail. And so, they would tie all their sutures tight, and then it would just totally scar over, and the whole thing would fail. So then they blame the Ologen. It's like, no, you need to. It's a new technique. I've done 100 cases. Here's how you do it better. So that was difficult. That kind of came. That was with us for about a decade. But then I stopped doing TRABs or Express shunts in 2016, so it kind of ended that. So moving on to ab-externo canaloplasty. Remember, this is all about moving forward to safer things. Robert Stegman started doing viscocanalostomy, and then iScience had this blinky red light LED microcatheter that is that was used to drag a suture through the canal and tie it tight. And these lessons that I learned from learning ab externo canaloplasty were really foundational for how to do new procedures today. So with the canaloplasty, there's another fight. The only time canaloplasty works is when there's blood, people would say, or you still never, because you had to do a deep sclerectomy. It was a hard surgery. You still never get paid for that. It's hard to do. It takes too long. It doesn't work. My favorite was canalocrappy. That's what they call it. So, but then, then they had codes so they can get paid. So then it was like, oh, well, maybe I should try to do this. This is often the case when people make excuses and are negative when things are hard and there's no money in it. But when validated by getting reimbursement or by getting purchased by a large company they know and trust, then they say, oh, we were with you all along, buddy. But I was able to have, I think by the power of the Holy Spirit, I was able to see that this catheter would be really helpful in pediatric glaucoma and doing ab externo goniotomies. And providentially, there was this short window of time where I was doing all the glaucoma surgery on children for the state of Oklahoma and for Arkansas, because the glaucoma surgeon in Arkansas, the one that was doing kids, had left. So I did like 16 trabeculotomies in 18 months, which is crazy for, a non-pediatric, it was insane. And I used all the iTrack microcatheter for these. And so I was like, this is God telling me I need to publish this. And so I did. And I published a case series in the Journal of American Academy of Pediatric Ophthalmology and Strabismus in 2010. And this was the first description of this technique. And it's a technique that's still being used. But then 2012, that's when the iStent came out, and which is kind of the quintessential MIGS. A lot of I was already doing ECP combined with phaco, but most people who were doing phaco, they just would, if they had glaucoma on meds and they were controlled, they just do the phaco and pray that things didn't turn south afterwards. But having something like this that's ab externo, minimally invasive, with some modest efficacy, really, was a huge deal. And I was like, this is finally where we're at. But there's a fight. There's still a fight. There's, and it was approved in 2012. But here's the thing: is people say, well, why would you put a piece of metal in the eye? This is going to bankrupt Medicare. The surgeons are only doing this to make more money. Sound familiar? I don't have any patients in my practice that would benefit from this technology. That's always my favorite. That's a hallmark of laziness, and the refusal to get out of their comfort zone. And then the one that I don't hear anymore, because I scolded people on the floor of the AGS for saying MIGS, minimally effective glaucoma surgery. I actually told them, I was like, you know what, people, 80% of people with glaucoma are taken care of just fine without you. Optometrists and general ophthalmologists do a fine job with and they don't need you. If you can't find people to use this surgery, you have what's called a referral bias. So, but really, this is really then I mentioned ECP. We're talking about personalizing interventional glaucoma, and this is kind of one of the ways God has used me, because I'm always thinking differently. I'm always like, well, how can we take a bit of this and a bit of that and put it together? Just because something isn't FDA approved to be done a certain way doesn't mean that you surrender your brain. That's FDA approval is for the companies, just defining what they can say and how they sell things, not how you can use things. So for 20 years, I've been calling to be creative and personalize the interventional glaucoma treatment for each patient and to show others the way, figuring out which patients to do ECP versus canaloplasty versus express versus tube. But really, we're just trying to stop people from going blind. And we're switching. Instead of switching prostaglandins back and forth and adding a fourth drop to push off surgery for another month, we have all these other options. And combining MIGS to have added efficacy if they have different mechanisms of action, depending on patient severity, number of medications, their pressure. So in 2016, before the Xen came out, actually I was combining OMNI and CyPass, and that was like my trabeculectomy killer. Now for me in my practice, it's either iStent Infinite or iDose, or iStent Infinite or OMNI plus an iDose, or ECP and Alloflow. That's another combination I'm doing. If you don't know Alloflow, we'll talk about it later. But but iDose is not MIGS. It's a procedural pharmaceutical that you can really combine with a lot of these things. I know Glaucos just donated a whole bunch of iDoses for charity to Jeff Tabin. So that's going to be exciting to see what happens with that. But he's asked me to come help teach that. So this is a new paradigm that's put forth. I know I'm over time here. Let me try to power through this. But it really, it starts with SLT. Don't put people. If you're putting people on medicines as a first line to treat glaucoma, you're part of the problem. You need to stop doing that. If you don't have access to SLT, you need to figure out how to get access to SLT. Incidentally though, if I were on the, if my mission field were third world and not rather than the first world, I'd advocate for first-line treatment to be goniotomy with a cystosome needle, just a bent cystosome needle. Don't start meds. You got someone you diagnosed with glaucoma in the third world, do a goniotomy right there. And a cystosome needle is what, 17 cents? I'm sure you can get some cheap viscoelastic. And then if you have to start meds after that, low-dose pilocarpine is actually indicated to keep the TM open, and you can usually get timolol and pilocarpine in most places. I think if you find a 35-year-old with glaucoma and you start with that, you may very well give them 20 years of seeing. So I'm particularly proud to have developed a safe technique for ab-internal goniotomy, followed by the first FDA approval device to ab-internal canal dilation. In 2009, Paul Badawi was looking for a glaucoma surgeon to help him with his new company. He approached Bob Stamper at UCSF, and I was humbled that due to my prior work with Express and canaloplasty. Bob said, you should talk to Steve Sarkisian. And so I met with Paul. We talked for hours about our shared vision for better options to help patients keep their sight. And he eventually came up with the name Sight Sciences, which I thought was perfect. So here's how this went down. It started as a stent company. Sight Sciences started as a stent company. They had a stent that was going to go in the canal. And in the process of designing that TM stent, they discovered that stent delivery system could go all the way around the canal. And they were like, we can use it to inject viscoelastic. And then they put the stent development on hold. And then as they were developing the catheter, they're like, well, wow, it rips through the trabecular meshwork. Well, let's put that on hold. But they developed the catheter to inject viscoelastic, and they eventually called it VISCO360. And then once they realized that the TRAB360 was going to be easier to get on the market faster because it was just like selling a scalpel, really, they did that. And so, and he and I were talking back and forth throughout this whole process. So July 3rd, 2013 were the first cases of TRAB360 in my OR, and a year later was VISCO360 and followed by OMNI. So this is the original TRAB360 off the line, and this is the email from Paul congratulating me on the first cases and my report saying how well the cases looked. Those are actually literally the first TRAB360s ever off the line there and sterilized and ready to go. So the industry partners are really my defense contractors. There's no growth without them. And, the research and clinical trials are an integral part of my personal journey with moving interventional glaucoma forward. You always got to put your patients before a company's bottom line. And I've told CEOs, actually, I'm like, I don't care about your bottom line. And I care about my patients. And you're just here to, I'm like, here, give me this now so I can, defeat the enemy. Here's just a small collection of seminal papers that we were able to provide evidence for interventional glaucoma. Lord willing, I'm halfway through this journey. But even while we sit here, all these companies, Glauco, Sight Sciences, AbbVie, Alcon, others, are expanding efficacy and duration for these products, and other companies are sprouting up to build on interventional glaucoma, which is really exciting. Some of these, the upper left is the pivotal data for the Infinite study, and then one of the iDose papers there, where I was able to be first author. We compared the Hydrus and the iStent Infinite and the Integrity study, interestingly, as a standalone without glaucoma, without cataract surgery, and showed superiority of the Infinite iStent over the Hydrus. So cool things happening that blessed to be a part of. So I just want to make a dent in the universe, one eye at a time. Unlike Steve Jobs, I intend to do it in Jesus' name. And after all, if we serve him, we serve at his pleasure. And I want to be clear, I'm not the center of this story. All the vain things that charm me most, I sacrifice them to his blood. If you profess to be a Christian but still believe in your heart that you are at the center of your story, surrender to his lordship now before it's too late. So, in summary, be curious, not judgmental. Listen to the naysayers, but don't let them stop you from doing what you know is right. Remember what Charlie Kelman said, while doctors debate, patients decide. Stay uncomfortable. Don't be a victim of your training. Question everything you do and be relentless in trying to do better for your patients. Be interventional. And most importantly, be incarnational. Listen to the patient, understand their lives, and treat the whole person. Remember, when our Savior came, he brought healing in his wings, and we are agents of that healing. You might see my people around during this. If you all, my wife is usually dubbed a saint when after they hear me give a talk, or they know me and then they meet her for the first time. But anyway, thanks for your time and attention. Won't you join me in pushing back the darkness together?
Okay. Quick questions for Steve. John?
How should we be treating uveitic glaucoma?
You have to repeat your question.
The question was, how do you treat uveitic glaucoma systemically? Make sure so basically start with, hit them with steroids, sure, but if that patient will go blind unless they get systemic treatment for their uveitis. So I find them a rheumatologist immediately, and I tell them, you need to put them on a biologic, especially if they have chronic inflammation, not just like the transient idiopathic inflammation, but if they have chronic inflammation or secondary inflammation, you got to treat the systemic source, and you got to be their advocate, because if you just turf them to their primary doctor, they're gonna, they'll get undertreated because they don't really understand this. Even the rheumatologists don't understand this. I have to say, listen, this patient's going to go blind unless you put them on Humira or something.
Steve, do you have a place for Xen, or are you just...
So Xen is what I do instead of a TRAB now.
Okay.
I mean, because some people, they fail all the angle surgery, and I have a conversation with the patient. I'm like, look, there's no cure for this. It's a journey. We're going to keep doing things. I have so many things to keep you going, but rather than doing, one big surgery that may cure you but also may make you also go blind, we're going to do a series of less invasive things on the way because as you mature, as you live longer, your other parts of your drains start to break down. As you get older and you have glaucoma, the aqueous production increases. So you have this bad combination. People are like, well, you did that surgery. How come it doesn't work anymore? Well, the surgery didn't fail. You've outlived its usefulness, and you're still here. And so Xen is what I do usually, and that's transient. That's going to be I'm doing fewer and fewer of that. Now we have good suprachoroidal things like the Iontrex Alaflow, which we can talk about later, but that's another cool thing that's just,
Yes,
Quick
thank you
question.
for serving as a pioneer. There's definitely an unmet need in glaucoma and sharing your spiritual journey. I have two questions. The first one is with these off-label combinations of MIGS, how do you, now that you're in the real world, how do you get reimbursed? When I was at Walter Reed, one kid was in the military system, and so he was able to use these off-label combinations.
yeah, so he's referring to Wan-Ai Kim?
Yes.
Yeah, he and I are good friends, and he talked early on. He and I talked many times when he was in his training, and you know, and
He
you
also
just have to
presented
be
at
more
COS.
selective. You know, like he would do things that was good for government work. You could that were just every case was going to lose money, but combining ECP and goniotomy is I mean, so there are things that are. Again, you have FDA approved things, but you have a license to practice medicine. Who cares what it doesn't really matter, is my point. Like, as long as you are smart about it. Interestingly, the only thing that I know we can't do anymore is ECP with iStent. That got people's attention, so they said no more of that. But with select carriers, you can still do ECP and goniotomy. You can still combine ECP with Alaflow. You can do OMNI with Alaflow. So there are still things you can be creative with. And then iDose is not a MIGS. They're trying to make it one. That's why they're trying to do this LCD decision thing. They're not going to succeed because they fundamentally misunderstand what the iDose is. It's not a MIGS. It's a procedural pharmaceutical. It can be done anytime you would give someone an eye drop.
Mm-hmm. And secondly, as a private practitioner, how do you manage patient selection and monitoring endothelial cell count in terms of baseline specular and those things that are on label?
I've stopped when I have a new patient, I stopped using my PackMate for pachymetry, and I actually use my one of my 5 endothelial cell counters that I have, because every company that I do a trial with wants me to use theirs. So I have all these, so I use that actually. So I get cell counts on all my new glaucoma patients, and then I get pachymetry as well. So that's really how I do it. And interestingly, I think it's stupid because we didn't have any cell loss with the phase 2 study of the iDose. The FDA, in their condition for you getting a second iDose, has that you have to follow their cell counts. I think they'll get that appeal, but because of that, now anytime I'm putting in an iDose, for sure, I'm getting a cell count just to make sure that we can demonstrate that it's appropriate. So you just got to measure it.
Hi, I have 2 questions as well. Right here.
We'll try to keep
The
those
first
brief.
is, again, about uveitic glaucoma. Imagine that you have a patient that has had all the systemic treatment and is calm, but has a condition where the uveitis may return, and they've got very high IOP. What is your current treatment for
So
that?
a lot of times they had trabeculitis for a while, and they might have some debris blocking their outflow. So I'll do OMNI on them, and it works surprisingly well. And then if that's not successful, then I'll put an OMNI valve in them.
Great, thank you. And then the second question is, I do work overseas in Africa, and I do a lot of GAT,
Yeah.
gonioscopy-assisted transluminal
With a suture?
trabeculotomy with a suture,
Yeah,
360
great.
degrees.
I think that's the treatment.
But I do see a lot of closure of that goniotomy over time. I'm wondering about, do you use pilocarpine versus cyclopentolate postoperatively? Do you inject any triamcinolone at the end of the GAT surgery? What do you do to try and mitigate that?
I think you can even use pilocarpine prophylactically from the beginning to keep it open, yeah, I would use it. I would use it for a few weeks at least. But then here's the thing: if the pressure starts to go up at 3-4 weeks, restart it, or keep it on. I mean, some people you have to have it on it chronically. There's some people that just have, especially if you're not doing cataract surgery, they're just, and they have thick brown irises, there's just that complex is gonna, those leaflets will close. So, but the earlier you treat someone with GAT, the better they are. Like, you know, like if it's, if they're in their 20s or 30s, you may very well have cured them.
Okay. Thank you very much, Steve.
I'm around, so.
Okay.
Thanks. Oh,
Thank you.
thank you.
Okay.